therapist in health science and bone health, I believe.
Exactly.
In an IRA and Bevan. I've been asked to point out to those who are joining us online that there is a mechanism for asking a question online. So you can put a question on there and then we can answer that for you at a later stage. So we better move into the program because we're running pretty late at the moment. So we're going to start with, I think, videos, and it's patient stories. So really important, patient stories, videos and messages from the Royal Osteoporosis Society.
Hello, I'm Jane Ansis. I'm retired for 8 years. I used to work as a midwife, sonographer in the University Hospital of Wales in Cardiff. I was quite surprised when I had my first fracture. I was aware that my grandmother had had a brace when she was probably 50 to 60 years old, but didn't know what the problem was. And I had the first fracture in 2010 when I was aged 58. I was abroad in Tunisia and I was walking down a hill and it was uneven. I even commented before I fell that the road was very uneven and tried to get a better place to walk. But I tripped and fell forward. I didn't realize that I'd broken anything until it started swelling up and I got on the bus, and I was determined to go and see some places of interest before I went back to the hotel. But by the time I got to the hotel, I had to be carried off. I just couldn't walk at all. And then I realized that something was up. So I got seen as an outpatient. I had a half cast put on, some painkillers. I was traveling back to Britain the next day, which I was pleased about. I don't think osteoporosis was discussed in the hospital, although when I talked to the GP, he thought it was unlikely. That was his comment. And it was normal, you know, I was normal weight, 9.5 stone at the time, had a good diet. I didn't smoke or drink, but I wasn't referred to any fracture liaison service. The second fracture was my left wrist. This was 6 weeks after the first fracture. I was actually looking at some pictures on the wall and fell down 2 stairs. So the fifth fracture in 2021, which was the distal right radius collis fracture. I slipped in the shower over the bath in a hotel in Hereford, and I vaulted over the side of the bath and ended up sitting outside on the floor, and I'd slammed my hands down. So I ended up with a half cast in Hereford as an outpatient and referred to the Gwent Hospital in Newport, where I was now living. It was a nightmare to get an appointment and transfer of details of care. 3 weeks later, I had an X-ray and full cast put on, but it had been set badly. And an operation was offered, but should have been done within 2 weeks. Therefore, I refused the op. I was left with carpal tunnel syndrome, affecting 3 fingers of my hand, which affected my driving, my swimming, and playing the piano. I had to wear a wrist support night for 6 months for carpal tunnel in my fingers. Other risk factors for osteoporosis that I have and didn't fully realise all of them was I have a family history with my grandmother having a brace on the back, which was query osteoporosis. I don't remember any history of a fall, but there we go. I was postmenopausal. My menopause was at 52 and my first fracture was at 58. And I had one ovary removed in 1987 when I was 35. The medicines used for breast cancer in 2018, I was put on tamoxifen for 10 years, or however long. On reflection, I do think these things should have been considered for risks for osteoporosis. If I'd known that I had 3 risk factors for osteoporosis at the first fracture, I may have taken things more seriously with my activities and emphasised my risks to the GP. Well, obviously, if it had been picked up a bit sooner, because it was the 3rd fracture that I ended up being sent for a bone density scan. And I was on the tablets for 3 years, and it seemed to sort of, well, they say improve, but I mean, probably static rather than getting worse. I think it has hit me more after the 5th fracture, because I'm now starting to think, oh, here we go. It's every 2 years I seem to do it. And I'm sort of bracing myself almost. And if I have a slight trip or anything like that, my mind automatically goes into this slow motion fall, as if it's going to happen again. As I say, the fact that I live on my own, it's a great, great inconvenience if I break something. And it could mean that I have to think about whether I go and stay near my daughter, or, you know, sort of actually moving. Even though I'm very active, and I don't, you know, I just carry on and do lots of things. I'm starting to think, I'm surprising myself really, thinking I do have to address this. What happens if I get hip fracture? Where am I going to stay? Who's going to look after me? And that feeling of, as you get older, I don't want to be an inconvenience to anybody else. I want to be able to cope.
My name is Leslie. I'm a retired 62-year-old specialist nurse. I've always worked in nursing for over 30 years in the UK and abroad. I'm married and I live with my husband in Gower. I had my first fracture, my first spinal fracture in November 2019. I was 59 and I just retired. I went to see the GP and an x-ray showed a fracture, a compression fracture of T7. It was a spontaneous fracture. I don't know how I did it. I just got out of the shower one morning and I had some back pain. And that got worse throughout the day and then quite severe over the next few days. That's how it all sort of started, really. That was the first time I'd had any sort of fracture or anything. My GP totally managed the whole thing. I wasn't referred onto anyone and nobody else was involved. Other than the x-ray, my GP managed everything. When I did go and see her for the results, she said, I asked about physiotherapy and she said to self-refer 12 weeks post-fracture, which I did. That was all. I didn't get any other input from anyone else. I must admit that I wasn't very compliant with my vitamin D3. It's not very patient friendly. At the end of the consultation with my GP after the fracture, of T7 in 2019, she made it plain to me that yes, it probably is linked, and yeah, she said, you know, you need to be more compliant with your treatment, which I certainly was from then. But I didn't have any other referral, and I didn't have a diagnosis of osteoporosis then. It was all just going on this scan that I had in 2004, which said I was osteopenic. See, he was going to arrange this DEXA scan, but unfortunately, he forgot to send the referral because it was only about 6 weeks afterwards. I was having physiotherapy, and I contacted the department to see where I was on the list, and they said there was a 14-month waiting list, but they also informed me that there wasn't a referral there for me. So I went back to the GP, and someone else did the form and someone else sent it in, but because of the time scale as well, I decided I arranged my own private DEXA scan. So that was the first time somebody mentioned that I had osteoporosis, but I hadn't really been diagnosed, and I didn't have a repeat DEXA scan to prove the results. Anyway, I went into A&E, they did an X-ray, they said I hadn't fractured anything, I was constipated, I was given an enema and sent home with an urgent colorectal review. So I got home, and the next day I was still in so much pain. I thought I'll try and get into hospital in the back way, and I'll ring the colorectal team and see if they can get me in. So I rang the colorectal secretary and said I was in a lot of pain, and they got me into the surgical admissions unit. So I went to the surgical admissions unit. To cut a long story short, they eventually did a CT scan which showed a fracture of T12. The admissions doctor consulted the orthopedics. Obviously, colorectal said I'm not constipated. They didn't want anything else to do with me. So the message from orthopedics was I was told to rest, mobilise as able. I was seen by a physiotherapist, given a walking frame because I was using a wheelchair at that time. And I was discharged home and told her to contact my GP. And by this time I was really desperate. Nobody was listening to me. So I rang the Royal Osteoporosis Society, spoke to one of the specialist nurses there, and it was probably the best thing I'd ever done. She was really, really helpful, really informative. She was compassionate as well, and she gave me some really good advice. And somebody was listening to me. She actually said that she was surprised that I hadn't had a referral to a specialist, particularly as I had risk factors and with my history. And she was quite surprised that I wasn't on a bisphosphonate. So she suggested I had an urgent review to a rheumatologist, and to start a bisphosphonate called Benostal, which apparently is a lot better for people with gastric problems, which I do suffer with. I feel that my GP failed me. He didn't, or she didn't at the time, act on my first fracture. I was also failed when I went into hospital because they pinpointed a fracture and they didn't even refer me to the correct people. So yes, it's been quite a battle, and I don't really want to see anybody else go through the same thing. I just couldn't believe that nobody was listening, and I do think if I hadn't have pushed, like, you know, I knew that going in the back door through the colorectal would get me in, but I knew my problem wasn't colorectal, and I don't think many other people would have done that. You know, questioning your GP. I mean, when I did speak to him the last time, I did say that I was strongly dissatisfied with the care that I'd had, and I pointed out that there was numerous missed opportunities to actually diagnose me an awful lot sooner. So yes, it's definitely, there are many people that wouldn't want to bother the doctor, and will just take everything their GP says on face value. I mean, I've lost my confidence. I mean, I rarely go out without my husband now. I feel isolated. Although I'm thankfully I am walking now, and I walk mostly without my stick, although I do need it occasionally. But I've lost my confidence. I don't want to go out. Yeah, so I do feel isolated. Before all this, I was an active person, and this has severely affected my life, and it's limited my activity. I mean, I went from sort of enjoying walking on the cliffs locally to being in a wheelchair. And that was, you know, quite a shock. I mean, I was so depressed, so depressed.
Well, I was feeling incredibly optimistic about everything until I saw those stories. But I mean, they're really powerful and really send out an important message why osteoporosis is so important, and these are not trivial events. I think the vertebral fracture one in particular is kind of a bit of a whole nother story. When we come to fracture liaison, we haven't got time to go into all the ins and outs of that, but thank you to the ROS for giving us those patient stories. I mean, that's why we're here, to provide FLSs across the whole of Wales to prevent us having to hear those stories again. So yeah, really powerful stuff. So I hand over to my co-chair now to introduce the next speaker.
Thank you, Mike. So our next speaker we're going to hear from today is Linda Scanlon, clinical nurse specialist, and Linda's here today to provide us with a bone health nurse perspective. So could welcome Linda to the stage. Hi, Linda.
Thanks, everybody. Really nice to meet you all. And I've got to say, I wish I could invite those ladies here today to see the passion in this room. And I hope that nobody sees that again in their service and nobody has to suffer that. So thank you to the RAS for providing that information. I work as part of the COTI team under the care of Dr. Singh and his guidance, along with my colleagues just there as one of the bone health CNSs with Sophie and the hardworking admin team, Jane and Jay, as well as we have some team members at the back there from the outpatients team who work alongside us with preventing falls and falls assessments. Of course, I don't underestimate the value of the CNS in the bone health and see myself as a link between the patient and their condition. I'm part of an always group, and I can see there's a lot of nurse representations here today. And I know that we all work under different directorates, but the role in bone health, as well as the fracture liaison service, no matter how varied or how difficult and challenging as well at times, is a very rewarding one. And it's proved to be very beneficial for most patients. I was going to say all, but after that, I would say most. So the role of the clinical nurse specialist in bone health fits really with us fulfilling our code, the Nursing and Midwifery Council Code of Conduct, and the 4 Ps, of which we are to prioritise people, practice effectively, preserve safety and promote professionalism and trust. And as you can see from the slides, there's a few sort of feedback that we've had from patients within the COTI CNS service as well. And it's been really beneficial to get that positive feedback, and it does help you push on. So the role of the CNS is varied and time is split according to the service and patient need, including patient identification and investigation. So each week, as you've heard from Sophie's talk earlier, we have weekly reports after Dr. Singh worked with the radiology department for patients over 75. So all reports that come through whether patients are fractured or not, and obviously patients who are under 50 go to a hardworking rheumatology team. From these reports, the CNS used to put the information into the FLS, but now that's taken over by Jay and Jane, and they put the information in, and we actually then, that releases our clinical time to telephone patients to be a bit more proactive and reactive as well, to release the clinicians' time so that they can see patients who are more complex in clinic face to face. So patients are usually telephoned within that 2-week period. We can offer face-to-face appointments, obviously, if it's needed, but to be honest, it's more about prompt risk assessments of falls and frailty and providing that treatment for patients. And like I say, that has reduced the waiting time quite significantly for the consultant in clinic. We also attend the medical clinics as well to assist in assessing as many patients as possible and reducing that waiting list. So a bone health nurse being that link between the patient and their condition, we can provide evidence-based pharmacological treatments, including denosumab, and hopefully before the end of the year, zoledronic clinics, and non-pharmacological treatments as well as multifactorial risk assessments and referrals for intervention. So the sort of information that we provide is in written and oral form in regards to low bone density, mineral density, and fracture risk, how osteoporosis and fractures can affect the person, the need for treatment, the benefit of treatment, and how to take the treatment correctly, how the timescale in which this benefit can be achieved, because I don't know about you, a lot of the time patients actually don't see the benefit of the medication because they don't actually feel better on it. They don't feel that pain relief, so they're not understanding how the medication actually benefits them. And then the follow-up and the adherence and compliance and tolerance as well has been really helpful. So we've posters, videos, demonstration models, some of which you can see at the back, and leaflets and booklets to go through with the patients, which covers different styles of learning as well as literacy skills. If a patient has denosumab injections, then they're given a patient information pack, which includes educational information as well as information on our service and a blood flow chart. Patients are invited for a self-injection program, and it's been slow on the uptake. Looking at the over 75s, we have some difficulty with dexterity, cognitive impairment, and some people just don't have anybody that they can rely on to be taught. But this can empower patients as well and reduce their number of hospital visits. I'd like to thank Kay Rose here today and Professor Stone from Cardiff and Vale as well, and as well as Charlie from Amgen for sharing their practice and knowledge, which has helped us start our denosumab self-inject program quite quickly. So the next slide shows the whole of ABUHB rheumatology and COTI patients who are identified. And the graph from the Fracture Liaison database clearly shows how a CLNS in bone health can improve patient identification of fractures. So the first appointed CNS in November 2021, it shot up, and obviously we did have a change in staff as well, so it did dip a little bit. But with Sophie now being in post and hopefully another CNS, we can carry on improving and maintaining above the national average as well. Prevention. I think obviously we all want to try and make the first fracture the last, but I think what we want to try and do as well is to prevent costly sort of fractures in the first place. And I don't just mean financial cost, but also the cost to the person. With the radiology reports that we have, not everyone is a fracture, but we always write out and contact people who haven't fractured. And just to try and explain that if you've had a fall, or if you would like some dietary advice, help and advice on reducing your smoking or alcohol, then please use us as the Fracture Liaison Bone Health nurses to provide you with that information first and foremost, so that you hopefully don't fracture at all. And also, there's also from today, I've noticed, and I've spoken to quite a few people today who we all want to work smarter. We all work hard anyway, but we've listened today whilst networking. And I think part of it is to promote the CNS bone health role across Wales. We would like to commence virtual rounds with MDT and CRT colleagues, as supported by the RCP and BGS. Also, we'd like to continue communicating with them, further developing links with our colleagues in A&E, MAUs, TNO, orthogeriatrics and primary care. We really need to improve the initiation of bone health treatment and follow-up, but that should be done, you know, with us all. That's not just the role of the CNS, but hopefully we can be that link. We have started, and we would like to develop seamless and integrated care plans with district nurses for treatment. We've found that we've been welcomed with open arms for that. We'd like to continue working on developing local pathways as well for treatment, and of course developing closer to home services, which is what the majority of the patients would like. ABHB, as you know, covers a large geographical area, and along with the self-inject program and also telephone and virtual clinics, we've been able to reach an awful lot of people, and I've been thankful not to have the wait or to actually travel into the hospital settings. Lastly, I'd like to say there's many quotes out there about not being a cog in the wheel, how derogatory that is. But I feel that without each and every one of us being a cog, then we wouldn't keep working. There would be slower movements in the progress of better bone health. And I feel that we all need to recognise and support each other's role. And I've been really thankful to be part of this today. And I'd like to thank Dr. Singh for his encouragement and support. So yeah, thank you all very much.
Great, thank you, Linda. I think we all agree about that real approach where we should all work together, whatever discipline, whatever specialty, whatever profession, that we'll only achieve this by all coming together as one, really. I think building on that, just like to invite our next speaker, Dr. Nimit Goyal, consultant radiologist, to explain to us the role of radiology in promoting bone health in Wales. Welcome.
Good afternoon, everyone. Thank you very much to the organizing team for inviting me, especially to Dr. Singh, for, first of all, appreciating the role of radiology and bringing us to this platform so that I can share that role with you, and then hopefully we can advance what we do in Aneurin Bevan and also replicate it across all health boards in Wales. So what is the role of radiology? I'm going to show you some images of various types of scans we do and show you how we can help. So this is an X-ray done, CT scan done on an 81-year-old lady who presented to A&E with abdominal pain. So there was no indication of backache, but this is a sagittal reformat done from that CT scan. And as you can see, it clearly shows this is what the normal bone height should be. And the two vertebrae above that show that the bone height is significantly reduced. Also to note is that the bone is actually very osteoporotic. It's very low in bone density. So these two are fragility fractures. Similarly, this is a patient sent for backache. So there was suspected backache, but there was no mention of whether there could be osteoporosis. So we can see that there are actually 4 osteoporotic fractures. You can see the front part of the vertebral bodies is much smaller compared to the posterior part. So 4 fractures. This is an MRI scan of a patient who was 70-year-old with pain going down their left leg. So this scan again was done for a different indication, not for suspected fracture or for backache actually. So this has again shown that in L1 vertebral body, there is reduction of height in the front part of the vertebral body in keeping with the osteoporotic wedge compression fracture or fragility fracture. So these were cases in which there was no fall. Patient, we were not expecting to see a fracture. But we also see several patients who come in with the expected to have fracture. So this is a 72-year-old lady who fell on an outstretched hand, quite similar to the patient story we heard earlier. So this is a typical fracture of the distal radius and ulna, and there is also a fracture of the scaphoid here. Again, to note here is that these bones are osteoporotic, but unfortunately, this was not reported on this report. Another patient with an osteoporotic fracture of the hip this time. So these patients came in knowing, and we were expecting that there is a fracture, but there was a missed opportunity because we did not call them fragility fractures or osteoporotic fractures. There is a separate group of patients, and this has been touched upon in the talk just before mine, that there are these patients who come in for various indications. So this patient has got ongoing pain in their hands, so they get an X-ray. There is nothing as such wrong other than the fact that the bone density is less than expected. So this patient has got osteoporosis. Similarly, another patient having backache with osteoporosis, no fracture there, but there is osteoporosis. And this is a pelvic X-ray, pain in the right hip, no fracture, but there is osteoporosis. So these are all opportunities for radiology department to liaise with our fracture liaison service and make these patients, provide a list to them and make these patients, make the fracture liaison service aware of these patients so that they can be started on a potential treatment if that's indicated. So this is role in identifying patients who do not have current diagnosis of osteoporosis. But once we have established that there is osteoporosis, there's another scan which we have talked about, DEXA scan, dual energy X-ray absorptiometer, or in simple terms, bone density scan, which is offered in radiology departments all across Wales. And basically, it's a safe, effective, and a very quick procedure to measure bone density. And what it does is it compares bone density in a patient against a young adult of the same sex. And then it also compares bone density against a similar age, size, and sex patient age group. And by doing that, it comes up with some numbers, which basically allow us to categorize the patient into either having normal bone density, osteopenic bone density, or osteoporotic bone density. And how that helps is it can help to stratify the risk of fracture in a particular patient. So why is this identification important? I know this has been talked about in several talks, but I think this is important. So 12% of ladies above the age group of 50 will have a vertebral fracture. We know that from prevalence studies. And that number goes up to 20% when the ladies are above age group of 80. But 70% of these fractures are actually undiagnosed. And then there was a recent study done looking at GP records within UK, which looked at the identification of these fractures in GP notes. And then when you look at that, it actually goes down to 0.1%. So only 0.1% of these patients are actually known to have a fracture in GP records. So that's a significant discrepancy in what prevalence should be and what we know about. Royal Osteoporosis Society published this paper in 2017. And in that, they say that vertebral fractures are a powerful indicator of further fractures. So we know that patients who are known to have vertebral fractures can go on to develop fractures of their hips or more fractures of their other vertebral bodies. We know that the vertebral fractures are underdiagnosed. And in one study in which patients who have had hip fractures, and then they retrospectively looked at their notes, and they had at some stage had a X-ray or a CT scan, which would have looked at their spine. And what it showed was that in 46% of such patients, the fracture had not been reported on that study. But what's even more worrying is that in the ones that were reported, there was no action taken. So the clinical action, both the radiological report missed the finding, plus there was no clinical action to follow up if it was reported. And as it has been mentioned in the talks before we took a break, all these fractures come at a cost. So there is an economic burden linked to these fractures. And if we can manage to reduce these fractures, we can potentially reduce that economic burden to the NHS. So what are the challenges? Why are we not reporting these fractures currently? So some of the issues have been mentioned in various talks, and some of the points that why we are not able to do it is because images get sent to us for reporting in a particular way. And as I showed to you all the images, they were looking at the spine from the side on. So if we do not have sagittal reconstructions, very often we do not look at the bones on sagittal reconstructions, and we miss these fractures. But as it was mentioned in an earlier talk, I think there is increasing awareness. There is awareness being sent out from Royal College of Radiologists as well. There is a national audit currently ongoing. So once we achieve all those things, I think this will become routine practice to report these fractures. So if we do report these fractures, then comes the second point that currently we call them various things. We call them just a fracture. We call them wedging of the vertebral body, or we just call them bones are osteopenic. Now, when it comes to the third part, because in Anur and Bevan, we have been running this pilot, which has been led by Dr. Singh, that we send, radiology department sends out a list every week. So the radiology department IT finds it extremely difficult to pick up these because there are so many various terms being used. So I think there is a desperate need to actually standardize the terminology we use to report these fractures. Plus the other thing, which is part of the entire spectrum, is that even if we identify and send on, we need to know as radiologists that something beneficial is happening. And at the moment, there is very much lack of awareness whether there is an onward service for these patients to refer to. Because an ideal report as a radiologist, what I would like to report if I'm getting an X-ray from a GP, that there is a fragility fracture, see in T11 vertebral body, kindly refer to fracture liaison service. And that is what we would like to see. So how to overcome these challenges? I think I've touched upon this. We need robust and ongoing education program. So the Royal College of Radiologists in their paper have said that there should be an osteoporosis lead for every health board, who should then be linked in with the fracture liaison service in that health board. And that radiology osteoporosis lead should also then go on to educate their own colleagues. We have got several platforms within the radiology. We have got several educational meetings happening, and they are ideal places for this radiology osteoporosis lead to educate the colleagues about the importance of reporting these fractures, about the importance of establishing a terminology which is accepted across all Wales. And then, as I mentioned in the second part, is that we need to strengthen our current IT systems and also adopt any new technologies out there. And one of the new technologies which is coming up really rapidly in radiology is artificial intelligence. So there is software already out there which can pick up fragility fractures, but then they need to be integrated with our current PAC systems. And the third step is always that once this report is generated, I think it will be really useful if we can have minimal human interaction in these processes, and these reports are generated and automatically sent on to the liaison services. So coming on to my last slide, this is the referral pathway we currently see for a patient. So we receive a referral, which can be from primary care, which can be from secondary care. It is for a variety of indications. So we scan these patients. So in scanning, I think as radiology departments, we need to adopt this approach that we always have that sagittal side-on looking reconstructions available for radiologists to review. When it comes to reviewing this, as I've already mentioned, we should have a osteoporosis radiology lead who can then champion the cause within radiology in every health board. We should have all Wales policies for what terminology we use, and then depending on that terminology used, that how is it picked up by the IT departments across all Wales, because they are slightly different across health boards. And once they have been picked up, then we need to have a defined service so that all these lists can be automatically sent on to those services. So this could currently look like this, that it could be going back to the original referrer, which could be GP. It could be to a rheumatology service. It could be to an osteoporosis service, or in some cases where there is already an fracture liaison service established, it could be going to that. But ultimately, I think all health boards require an FLS service to which all these reports can then be filtered through to. Thank you.
Thank you, Nimit, for that insightful talk into the role of radiology. No doubt that radiology has a big role to play in an FLS. Out of interest, we're running an AI study looking at identifying vertebral fractures, 5 centres across the UK. So yeah, interested to hear you speak about that. So we'll move on to our next speaker, who doesn't really need any introduction, partly because he's already introduced himself as a chairman. So I'll hand over to Anthony. He's going to talk about understanding and reducing the impact of fragility fracture. Thanks.
So I supervise clinical lead for all 3 of the audits run by the RCP. This is a report we wrote a couple of years ago, trying to pull all of that together for Wales. It's been influential in getting us where we have, not as influential as India has been. But we do have a perfect storm at the moment. We've heard today that we've got Welsh government, they've really nailed themselves to doing this. We've got commitment from the minister. We've got Chris Jones being very clear that it's unacceptable. It's legally unacceptable to be not doing this to patients. We've heard that it costs 3 times as much. If you want to write a business case, it's difficult. It costs 3 times as much not to have a fracture liaison service as it does to have one. And you see, we don't really need to talk about money ever again. The money is already there. It's just being spent on the wrong things. It's being spent on ambulances parked outside the hospital, on empty theatres, or theatres not providing elective activity, on people getting the wrong care at the wrong time. And we can change all of that. And your boards are all invested in doing that. Peter's workshop this morning was a very nice demonstration that, again, he's not, as a board member, he's not really interested in the money. He's interested in changing the quality of care provided to people. So we need to be trying to pull together what we're offering in terms of quality. How we do that, how we write a business case, how we put together everything is something you're going to have to go away and do. We've got brilliant support offered by Craig on behalf of the ROS. They've got all of the numbers that you could possibly need. They've got all the templates. They've done this. They've written business cases in the past. They're there. You could just nick somebody else's. It's not different in another health board. It's going to be the same words, the same things you need to put together. There is support for doing that from the ROS. You've heard from Ali Doyle talking about the Academy network. That makes available networking support for people trying to do this who might feel isolated, particularly if you're working in an area where there just isn't any leadership for this and you're trying to take this on. And then the final thing that Peter talked about is the need that if you're going to try and do this, you need to be able to evaluate and prove that what you're doing is working. And proving that for fracture liaison services isn't as complicated as you think. You do not have to prove that you're reducing fracture numbers. That's a really difficult piece of research to do. What we know is that patients who've got a bisphosphonate in them don't break as often as people who haven't. Patients who are on osteoporosis treatment don't break as much if they fall as people who aren't. So you need to just be delivering people who are on treatment. And we have a national clinical audit, the Fracture Liaison database, that provides you with the feedback. And Linda showed us exactly that sort of feedback, that graph that she showed of the impact of turning up to work and transforming things in her hospital. She didn't have to do any work for that graph to appear in an authoritative output from the College of Physicians. She had an enormous amount of work to get the data in to do that, but she didn't have to create the demonstration of her effectiveness. So we've done that. We have the opportunity for you to all do that in different areas. And I can take you through some of what's available in terms of that support from the RCP audits. The third of the audits we haven't really talked about today because it's not very relevant to fracture prevention is the National Audit of Inpatient Falls. And Falls is a completely different meeting from today. But the audit's there, all of your hospitals are engaged in it. It's really an important topic. The National Hip Fracture Database, which is the one that I've been most involved with, is using hip fracture as a way of challenging the NHS, looking at what happens to somebody who's old, breaks a hip, how they managed as they bounce through the complex systems within a hospital. It's not just about broken bones. It's not about the metalwork. I don't care about the metalwork at all. And the patient doesn't know what it is. It doesn't matter. It's about the person and their experience of passing through the modern NHS, which is often really very poor and a real struggle for them. And one aspect of that is osteoporosis management. We've got data for all of the hospitals to look at numbers of hip fractures in different areas, what's happening to those patients and the quality of care being offered. Take an ideal hospital to choose, for an example, in a situation like this. So this is Usman's service in Neville Hall before Neville Hall was taken over in the greater concern of a wider Gwent model. But we've got key performance indicators which measure the quality of the service that's being provided there. Those figures give you a really clear idea of what happens to that patient and what her experience is when she comes into a hospital with hip fracture. That data is all freely available. You can look it up on your phone now for my hospital, for your hospital. It's all immediately available, and the data that pours into it is live and very accessible. And it means that we can plot what's happening to individual patients as they pass through the system in these live graphs. This is a graph for my hospital looking at how some of our key performance indicators, the quality of care that we're providing, changes from month to month. This is so available that Welsh Government, supported by the delivery unit, have taken these graphs and they've stuck them on the desk of the chief executive on a quarterly basis over the course of the last few years. It's a great way of feeding back change and challenging hospitals to do. And that's broadly what's happening in terms of fracture liaison services now. The same sort of potential to try and drive change and show that change is happening and question why it isn't if it isn't. And we know it works. This is the result of the Welsh Government Performance Management Programme over the course of the time. So on the right-hand side, the dark line at the top is the Welsh mortality after hip fracture. 10–15% below it for years is the English figure. And then the Welsh Government started taking this seriously, investing effort and our attention in it, holding us to account. And you can see we've got a better mortality figures than England since then. So this works. This is a strategy that works. And this is what we're trying to get set up in terms of other aspects of care. The audits, I've got data on 750,000 patients. I could do all sorts of stuff, but actually she does the work far better. So what happens to the individual patient? And the audit, it doesn't audit what metalwork goes into her. It audits what her experience is of her care as she passes through hospital. And it asks the same questions of the data of care that she asks me when I see her in casualty. This is the same sort of set of questions as the lady who I saw this morning in ED would be asking. There are a range of key performance indicators, but key performance indicator 7, it's a new introduction, is a key question that we need to be asking for every patient. So this lady has seen a whole range of people before she gets to see me. She's seen the ambulance staff, she's seen ED staff, she's been for an X-ray, she's seen the orthopedic juniors, she's seen a nurse. None of them are responsible for making sure that somebody does anything to prevent her fracturing again. At some point, the buck has to stop and somebody has to do it. And because she's got a hip fracture and I'm going to look after her, or my colleagues are going to do most of the work, because we are going to see her, we have the opportunity to get on and treat her and make sure she goes on to osteoporosis treatment. And that happens across the country badly. Across the UK, half of people in this situation get onto any form of osteoporosis treatment during their time in hospital. The other half don't get anything. Half of the people who do go on to treatment go on to an oral bisphosphonate, and very few of them have any follow-up to make sure they continue taking it. So what can I tell her? I can tell her that in my hospital, we're very likely to give her an injectable form of therapy that we know she will be continuing to benefit from 4 months down the line. We have a strategy for doing that. We're doing it very effectively. And we've done that because we've tried oral bisphosphonates and it doesn't work. Some people might prefer to go onto an oral treatment, but they're going to need somebody to be following them up to make sure that works. A fracture liaison service to make sure that they're continuing to stick with it, that their GP is actually aware that it was started in hospital, that the side effects that they've complained of don't lead to them just stopping it. And we just are trying to avoid them ending up in the ghastly stories that we've heard from the ROS videos. So that we can tackle. So we've got ways of doing that, but that's not happening everywhere. So if you look at the performance for different hospitals around the country, this question of, are you going to start me on something and make sure that I can continue taking it? The answer is no. More often it is yes. The vast majority of people may get something offered to them that they can't continue. But there's enormous variation, and in many hospitals, and a lot of these red hospitals doing very little are in Wales. Many hospitals, there's just no structure to make sure that people are on a bisphosphonate, and people on a bisphosphonate, people on bone protection bounce when they fall over. They don't if they're not on treatment. The fracture risk is treated. That tells me that this group is safe or isn't safe. We don't need to do much more monitoring than that. Even if you're on the best of treatment, there's still a risk. So in this study, we've taken data from people who presented 4 years ago with a hip fracture, who went into the care of a fracture liaison service. They had all the bells and whistles of support. They had the best possible, best available UK treatment, and still 1 in 20 of them broke their hip. So even with the best of treatment, we can't eradicate risk of hip fracture, but many of us are working in hospitals where that process isn't tried at all, and large numbers, more patients will be back with a new hip fracture. And I'm sure you all have met people in with their second fracture, their third fracture, their fourth fracture, who you know the name of the patient when they turn up. It's a dreadful thing, and it's our fault. It's not their fault. It's our fault that these people are coming back to us. So we need to challenge that. So we can look at how key performance indicators in Wales work for this question. For KPI 7, and you can see there are 3 hospitals. Those are the hospitals that are contributing to the FLSDB, who can tell us that they have patients on treatment. They're in green. They know that proportion of their patients are on treatment 4 months after. There are fracture liaison services elsewhere. There are geriatricians, others providing secondary prevention in some of the other hospitals. But if there's no follow-up, because there's no fracture liaison service structure, it's not going to be much use. And those in the red zone need to challenge it. And that's what you're here for. That's why we want to try and support you in getting fracture liaison services set up. If she'd broken a different bone, so if she comes into casualty, she's just lying in casualty with a broken ankle. What if she'd come into the casualty with, Chris once upon a time used to see her because she'd had a coronary, and somebody tried to send her home without giving her clopidogrel and a beta blocker and an ACE inhibitor. He'd have had a fit. The junior doctors the medical students on the ward, the nurses on the ward, the pharmacist on the ward would have had a fit if she would try to send home without secondary prevention. Obviously you do it. If she comes in with a broken wrist, shoulder, pelvis, we don't bother. It's just as effective as any of those agents for preventing another coronary, but we just don't bother because it's only a fracture. So we've got to challenge that. If she's come in with a broken wrist, a pubic ramus fracture, she's going to come through a whole very complicated path of people. Numerous people will be involved. None of them are immediately responsible for it. All of them have the opportunity to notice that she's there. Radiology can spot that there's a fracture, that there are indications of osteoporosis. They can flag it. But we need a common pathway where all of those flags go and are sorted and managed, and people do something about it. And that's what a fracture liaison service is about. And we need to do something about this. The priority of implementation of fracture liaison services set out in this very ancient Department of Health priority document. Hip fracture patients are the obvious first target. They're easy. We've got them. We've got a month with them in hospital. We can do something about that group of patients really easily. It's unacceptable that we're not doing it. There's no way we can justify not doing it. And it's very easy and cheap to do. other people with fragility fracture, we're not picking up anything like effectively enough. The vast majority of them, I'm sure Inda will show you the figures, are slipping through the net in one form or another. Those people together add up to this. Half of patients presenting with a hip fracture have previously waved a fracture and osteoporosis at us, and we've ignored it. And the duty of candor that Chris threatened, I think himself with, rather than he's threatening us, but as threatening us with, of admitting to these patients that, well, we had the opportunity to sort it out in the past, and we're very sorry we didn't bother. That really does need to galvanize attention amongst us. The FLSDB gives us a sense of what's going on. You've seen slides from this previously. We've got 3 hospitals providing data to the FLSDB. Those hospitals have a tool that can already start to put pressure on the chief executive. If you've got a fracture liaison service, any form of liaison work going on, any form of secondary prevention, and you're not logging it, then your chief executive won't even notice that you're not doing it because they won't get a report. So you need to engage in this. And this is a very powerful tool to make your life easier and to bring resources in your direction. Our figures are not very good across the country. And there's a real challenge to how we try and tackle that, even in the places that have got an FLS. None of those red dots are green dots. And we've got to invest in every single part of the country. I'll leave you with my details in case anybody wants to contact me. And there are some videos on my Cardiff University page if anybody wants a sense of how we do secondary braces.
Thank you very much indeed, Anthony, for that great talk. In the interest of time, I'm going to move straight on to our next speaker, who has organised this whole conference, and what a fabulous job you've done, and we're very grateful to you. I don't think you need any further introduction, so over to you.
Well, thank you, Mike, for having me today. And I don't think I can thank everybody enough in this room and those who are in the virtual platform for their support and for dedication and the energy what you have shown today. All the sponsors, external speakers, Ali, everybody else here. So we have heard about the service aspect today, and we also heard about the number game, what's visible in the database. But that doesn't mean that everybody is not delivering a service. And I think I'd like to put respect for those teams and services who are actually delivering the services, starting people on bisphosphonates and other treatment, whether it's a false care plan and whatever. But for some reason, it's not recorded on the FLSDB. But what are facts we have to base our today on the FLSDB results. But my respect is with those teams whose teams are not on the FLSDB. Now, we heard about the regional variabilities and the type of services we have in Wales. So me, in my role as a National Clinical Lead for Wales, I am your voice. And this is how I like to start and close this loop. Because what you have told us today, if you have put on a hashtag, all those views are not going to be lost. We are going to go back and look into those views and all those questions and comments you have made for us. We need to look at that and see how we can take your voice back to our network. And then following on I would say, the person who is coming after me and who actually helped me so much, how we get it to the government. He's a partner in crime. So I think that's what we are looking for. And then my role is also to work with everybody else, how we can overcome those barriers, how we set up our priorities, what we need to do. What are those framework we have to have so that this process is not stopped here today, so that when you come back maybe a year later or 5 years later, you can see that progress and we can see that in a way that is evidence-based and is documented here. So we know that we can have variabilities in our services, and there could be several reasons for that. It could be the delivery within the health boards, could be the outcome related. And Peter, I think when we speaking in the morning, he was referring to about the population approach. Forget the money will come. If you improve the outcome for the patients, what matters to the patient, what value to the patient, everything will improve. So that culture, that belief is something we need to change. And that's what we are signing up for. There could be some decision making. We heard about the coronary artery or thrombolysis earlier. That's fine. But that doesn't mean we should not go back and share the evidence what we have. But how? How we can do that? And I've put the reference for the textbook where I've used this, the outcomes as well. It's about evidence-based. We have seen the standards today from ROS. The team has just left. We need to use that. We got the audit results, and we also have got some direct feedback from the patients. That's enough to overcome any of these barriers. Now, this is the slide which I refer, and it does come with respect for those teams. But if we look at this number, the variability is very visible. But if we look at the 80-50-80 approach, that based on the FLS standards, we have to identify 80% patients. And we can see where we are within the health boards. And if we look at all Wales, the figure is about 9%. But when you look at the 50% aspect, which is that we recommended the treatment, we are green. So which means we should congratulate ourselves that once we identify, we're not that bad. But then we go to the next 80%, is that are we delivering that treatment evidence-based following the next 12 months? Because that is the time when people will stop taking these medications, either because of side effects or lack of knowledge, awareness. And we need to be thinking about that, how to improve that. And that's where our primary care colleagues, the nursing colleagues, what we have seen, and education steps in. But as we go down the line, if we have to see total number of patients, if I put a simply 20,000 patients in Wales having a fracture, we're actually giving evidence-based treatment as per recommendation to 200, so which is 1% of the population. So we need to do something differently, though we are actually identifying approximately 10%, but not treating as far. And as a result of that, the work which we see in our hospitals, whether it's the fractures with the hip, it will not stop, it will continue. The medication doesn't work under 12 months. How do we do it? What we have to do? And this is something which we have been working as a team. And this is one of my key role, is to develop those national strategic framework for osteoporosis for people living in Wales. It has got a quality triology. We need to have a planning part, but it's a quality planning. And this is what Chris was talking today. We should not forget about the good practice, the good pocket of work, what we have widely across Wales. It's not only one site or one health board. How to get that going, how to get that sustained and spread to the other sites. And this leads to the quality control, which is about the quality management and then quality assurance, which comes into our group. So based on all what we have set up 3 priorities. The most important part remains identification, management, and care of those patients. The number 2 becomes as the integration and partnership working. We need to start thinking, where is the third sector? Where is the Royal Osteoporosis Society? Where is FAN? Where is our patients? So we need to integrate with them and get to that, what matters to our communities, what matters to our populations. And finally, it comes to the education and awareness, which my colleague Linda was talking about. It's not only the education and awareness for the patients what matters, it's for radiologists. I met my colleague from a trauma and orthopedic today, and there are people from A&E, our trainees. That awareness is needed at that level. When a person with a fracture come to a hospital, it matters to us. It's exactly like coronary artery problems. So what I describe bones in my own words is the bones are living organs, just like your brain and heart. Please respect them. Now, how do we do this? How we develop that? We need to have our principles. And those principles are actually written by the Welsh government because I'm paid by them. I have to respect all those principles. So if we look at the prudent healthcare principles, or if we have to have a healthier Wales proposals there as well, care closer to home, it should be equitable services. It has to be sustainable. But end of that, accountability. And accountability has to be with the government. And that's what you heard from the minister today. And that's exactly what we have to do for the next part. Now, you have seen this slide before as well. It's a very simplest version, I'm going to say. Investment is 2 million on a saving, or effective benefit is 7 million. So cost saving is 5 million on an annual basis. I don't need to say anything more about this slide. I can rest my case for this. So, and if we have to underpin all those principles, our priorities, everything, and we have to keep this momentum. We have to have our network, which we have put it out as the FLS development and quality assurance group, which will underpin all those principles. And this is the group which has been today and acknowledged and endorsed by the health minister. So it simply means All the Welsh Health Board executives have actually endorsed and signed for this. All medical directors, nursing directors, and therapy directors are aware of this and fully happy to assign us those clinical lead teams from the health boards who will be participating in this. We also have a dedicated primary care lead, including radiology and colleagues from the pharmacy. And that's what we're looking for. We do respect a lot of nursing colleagues. And that plan here is that how can we develop more roles for a nurse consultant or a pharmacist consultant as part of this development at national level in all Wales. And then we do have a head of older people, Gareth, who was here today for a whole day, and he's fully supported this. And then we have ROS member and patient representative to this, and I'd like to thank Dalit for that. Now, if we had a group, we have all this, so what? And that so what is that the key part for us is that we should be signed up and dedicated to improve and support the delivery of care, what people with fractures need and what they deserve. And following on that, we take that responsibility and ownership of those things. But much more importantly about that is how we continue to develop this and take it to the next level, and how we reflect the key findings what Dr. Johansson has shown in his slides about the audits. That's a live audit. Anyone in the public can just go back and see how we are doing. But if we do not participate, we are not going to win. We're not going to impress anybody that how we are doing. So that's the key part of us, how we advise our actions. If we have done something, and how we take it to the next level, whether it's at regional, local, national level, but we have to come together as a team that we should continue doing that. And finally, that we have to have a mechanism to identify that good practice and disseminate that practice to the other health boards. So I like stealing things from others. I don't want to reinvent anything. I'm really good in stealing. But if anybody has that, I do that. And then finally, put all these things together. So basically what I've described when I met few of you is your voice, and you have paid me indirectly or directly, and I'm your voice. I'll be taking all those things back with my colleagues within the Welsh government, putting it back to the health minister, and health minister will endorse it. And my partner in crime has got a special way to do that. So I'd like to conclude today that our collecting aim should be that let first fracture be the last. Today, when we leave this conference after the next speaker, that we need to offer very prompt and cost-effective treatment, and we should be thinking about organizing and developing the FLS services, and you had those workshops this morning, and care closer to home, and avoiding those admissions to the hospital remains the key, not for the economic benefits only, but what matters to the patient, because they like to live in their own homes independently, and they deserve that dignified care. That's all from me. Thank you for having me today.
Thank you, Inda, for giving us that framework for progress. And thanks for all your hard work in setting up this group. And I think we can really go somewhere with all of this. So our final speaker is Kevin Francis. Kevin's also had a big role to play in organising this meeting. So thank you very much indeed for all your help with this. The title of his talk is Putting Policy into Action. So I presume he's got a cheque in his pocket for £1.9 million. So
Nice
thank
try.
you, Kevin.
Yeah. Okay, thank you, everybody. So I am Kevin Francis. I am a major health condition policy manager within Welsh Government. I also have a dual role, which is I am the programme manager for the National Clinical Audit Programme. So if you've ever had to put any data into any audit programme, that was kind of my fault. I apologize, but it matters because not only do I get to see that, I get to work on the policy in Falls and Frailty. I also look after musculoskeletal conditions and persistent pain as well. So very interesting areas and quite related as well. So I'm going to be quick because a lot of what I've just said, the minister said. So first of all, policy context. Here's what guides us in Wales. In 2018, we published this, Healthier Wales. And what we're looking for is person-centered approaches. We're looking for services that keep people well, not just fix them. And we want people to live the best way that they possibly can and to measure what matters to them. Last year as well, this hasn't actually been mentioned today, but it's quite important in my circles, and you know, I work in policy, so it's quite boring possibly to a lot of you, but for me, it's really important. So last year, the National Clinical Framework was published, and it's about measuring our pathways, our networks, and focusing on quality. It's been mentioned a lot today. The other thing it does is it wants clinicians to have leadership. And that doesn't mean that you have to have a title. That means that you own yourself and your service, and you have a voice that needs to be listened to. We talked today about evidence-based and the workshops, and others did it a lot better than I did. What I would say is the political will for change has been quick and amazing, quite frankly. About 3 years ago, when I was asked to look at the 3 national audits, I remember sitting in a room with Mike, and he told me, yeah, but no one cares about FLS. And the fact that I've had the minister here today with the chief executive and everyone else it was unfeasible a couple of years ago. So really chuffed that we're doing something. Best return of value of services. That sounds like it's money. It's not just money. It is about the value of the service for the person and the clinician themselves. We want you to have job satisfaction at the end of the day. We want you to feel that you're doing the job that you're meant to be doing, and not hamstrung by powers that be, if you like. We need to use the data from clinical audit and other data's proms and prems, patient experience and everything like that. And this has been the biggest change for me, is the burden of disease. So instead where you'd have major health conditions, which basically were considered important because of the levels of mortality, the numbers you've seen today show how important that FLS and MSK and pain, how many numbers of people are affected across Wales. So before COVID, the situation was I was given the task, we have to do something. So my first job was, I'm going to appoint INDA, because that makes sense and it obviously works. But we had limited levels of stakeholders. We only knew who we knew. We weren't really being reached out to from the community. We looked at things from a medicalized model. How do we get people through the hospital as soon as possible and just fix their hip and see you later, thank you. We didn't sit anywhere. We were almost an orphaned area of policy, where we didn't really have the right people to go and shout to. And because of that, it was limited progression of service development. Obviously, the pandemic delayed what I wanted to do, which was this a couple of years ago, but we're getting there. So where are we today? We have a wide range of interested stakeholders, and thank you all so much for coming. We're looking at it through the value-based healthcare, what matters to you, what matters to the person, and how do we get the best investment back. We have been placed within the Planned Care Board. That's huge. Probably not to anyone but me, but it is huge, and I'll go into reasons why that's huge now. And we have leadership, and I want to reiterate, it's not just Inda at the top or being your megaphone, it's every single person in here. So we are starting our group, and that will sit under the Falls and Frailty Fracture Audit Programme Strategic Group, very easily to say, which we established December 2019, so it hasn't necessarily had the drive that we need it to. That now sits within the Planned Care Board, and we've created MSK and pain networks which will work alongside. Now, the Planned Care Board has the minister, it has the health execs, it has the Welsh government, and it has planning. It has all the people that we need to talk to, and that is such an important part. So instead of coming into our group in blue, coming together, coming up with the best ideas possible and having nowhere to go to, instead now we have that ladder above us that we can actually raise. To finish, key messages from the government. We are open, our ears are open, and we're here to listen, as I hope that you've got today. So first of all, please don't expect anyone to try and make these changes that you want to see for you. We've got to do it collectively. You have a voice and you have support, as I hope that's been shown today. Please use it. We're here. Our emails, our telephones are open. We want to hear from the clinicians. We want to hear patient voice. We want to hear from everybody involved, third sector, everyone. We're not just looking for issues. The database kind of shows us our issues as well as others. We are looking for solutions. We want people to come up with the right ideas. We're all on the same bus trying to get to the same place, and we might argue about which directions we go, but we're all trying to get there. So please just I just want to be clear that there seems to be no disagreement amongst us that we need FLS in Wales. So it's just, and we might disagree on finance and stuff like that, but we're going to get there. Just bear with it. And lastly, as we've heard today, we really want to make Wales the exemplar. We want to show off because we're small enough that we can make small changes and have huge results at the end of it. And as Anthony showed with the hip fracture, sorry, you're there, showed with the hip fracture database, that was the first thing that I was asked to look at. And with Anthony's help, we've managed to stop people dying. And that's amazing. That matters. And this will matter to everybody who is affected by it. So that's going to be the last presentation today. Inda's going to close off, but thank you all for coming. And I hope you've enjoyed it and I hope it's been useful. And yeah, please get in touch. Thank you very much.
Well, thank you, Kevin. And thank you, the chairs, Peter, Mike, thank you. Now, our next steps are to utilize the information gained today, establish our group, and ensure we keep this momentum going for the coming years now. I would like to thank you all for coming today. It's heartening to see so many people interested in this area. If you're interested to take any more leadership role, please get back in touch with us. We are here for you. Now, so many people were involved today in making this happen. Kevin, thank you. Number one, to start with. I know he didn't want me to thank you, but this would not have been possible without you. I'd like to thank all the colleagues who have been hosting all the stands, to name few, Eddie, Charlie, Trudy, Stuart, everybody, my colleagues in the back, with the care pair, Neil, so good to see you. So I think this workshops would not have been possible without the help from the volunteers. So I'd like to thank all the volunteers and others who came in this morning to help those workshops. And this workshop brought in a very informal way to introduce ourselves to each other and get the perspective from everybody. So those who did the workshop this morning, thank you again. And Sophie, everybody was great here. Thank you all. Now, I think we'll all agree that this has been a wonderful venue. We have been served very nice food, and All Nation Centre staff needs thanks for that as well. And I'd like to thank all the staff, my IT colleagues. Tony, you have been very kind and being there for a whole day. Pass my regards to Jonathan as well. Now, we're going to Lisa. Lisa is the lady behind the scene who has been working, and all the badges, the days, the registration, you name it, the program, bringing us here, teas, coffee, handling mine and Kevin's flutters and anxiety. I don't think we would have done that. We haven't done this before, and we are not the program or conference organizers. We are just simple clinician or managers, but I think she managed to put us mind to rest. So Lisa, thank you wherever you are. Now, we hope today has whetted your appetite for more positive change. Thank you again for coming today. Please drive home safely, and we look forward to see you working together very soon again. It could be either quarterly basis via the group which we have, started today, or we may go for your feedback, which you put on your hashtags Bone Health in Wales. And if we need to develop that annual event, we will do that. And I can promise Kevin will support me to arrange a free event next year again. Thank you, everyone.